Well, good afternoon or good morning to some of you, depending where you are across the country and territories. But welcome in to our Learning Community Series, Session 1 here, our series on supporting healing after suicide for service members, veterans, and their families. And you're all here, hopefully in the right place for Session 1, introducing the CCBHC Toolkit, Foundations for Engaging Service Members, Veterans, and Their Families. Welcome in. Next slide, please. Well, you may be used to seeing Chantel leading these, but I will be your navigator for this one. My name's Phil Patty. I serve as a project associate here at the Service Members, Veterans, and Their Families Technical Assistance Center at Policy Research Associates, Inc. Happy to be with you all and excited for our presentation today. Next slide, please. All right, disclaimer, the views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Substance Abuse and Mental Health Services Administration, U.S. Department of Health and Human Services. Next slide, please. All right, our agenda for today, after just a brief welcome here, we'll get into a little bit of introductions for you all in the chat box. And I see some of you are already doing that brief overview before we do head into our presentation that you'll all be hearing from Duane France today. And we will have some integrated Q&A, a few spots for us to really have some good discussion with some leading questions there as well. And then we will also head into a short wrap up. Talk through kind of what's next in terms of this series and send you off on your way. Next slide, please. All right, a few housekeeping items before we do get started here today. Go ahead and set your name to how you'd like to be called on. When we do get to the discussion portions of the presentation, just make sure that you don't kind of have a preset name, that it's accurate in terms of when we do get to that discussion portion. You don't need to use any AI transcription. You can use Zoom's live transcription settings instead. Recordings and all that good stuff, copy of the slides will be made available after our meeting concludes here as well. When we do get to those discussion portions or throughout the meeting, please turn on your video if you are able. Gives us a little greater sense of community in the virtual space. And then along with that, mute any background microphone noise when you aren't speaking to the group so we can hear everyone loud and clear. And then along with that, especially for the discussion portion of things, use that raise hand, and the chat function is always, of course, available throughout the presentation as well. Next slide. Okay, our three main objectives here for this learning community session. One, providing an overview of SAMHSA's CCBHC Toolkit for engaging service members, veterans, and their families, including its purpose, structure, and key focus areas. Secondly, to explore strategies for identifying SMVF clients within behavioral health systems and understanding military and veteran experiences that may influence care engagement. And finally, highlighting key partnerships, clinical considerations, and life circumstances that support coordinated veteran-informed services across CCBHC settings. Next slide. All right, and now we'd love to hear from all of you in the chat. If you wouldn't mind putting in your name, agency or organization, as well as your state, territory, or tribal affiliation. And you can put that right in the chat, and I see some have already started, so thank you and welcome aboard. Next slide, please. And as we are all entering our welcomes into the chat, again, I just want to say if it is your first time with us in terms of a learning community series or session, we want to say thank you for being with us. These are definitely a great opportunity for us to hear on specific areas of expertise and really lively discussion to be had as well as these follow a three-part series. So thank you all for joining us. And thank you for entering your hellos into the chat as well. Next slide. Okay, quick poll question to start things off. What best describes your role or organization? CCBHC staff, leadership, state authority rep, community partner, veteran or military support org, or other. And if so, please go ahead and enter that in the chat. All right, thank you. All numbers rolling in. And this will give Duane a good sense of who we have in the audience here with us. Okay, thank you. And we'll end that. All right, so it looks like the majority of folks from a veteran or military support organization, and a good smattering across the board of community partners, with maybe our lowest numbers in that leadership or administrator CCBHC position. Thank you all, and thank you all for entering those others in the chat as well. All right, next slide. And with that, I will hand things over to Duane France, co-director of SAMHSA Service Members, Veterans, and Their Families TA Center here at Policy Research Associates, Inc. Duane, I'll hand it over to you.
Thanks, Phil. I appreciate it. And I appreciate everybody taking their time out this afternoon, and really appreciate the answering the poll question. Definitely helpful for me to, as Phil said, see who's in the audience, and looking forward to how this might be able to support you in your work, regardless of where you're at. Really glad to see some familiar names in the chat, as well as some new colleagues that I haven't met. So as Phil said, I co-lead the SMVF TA Center. In this past year, we had the honor and the privilege to be able to partner with SAMHSA to develop this toolkit called Engaging Service Members, Veterans, and Their Families, a toolkit for certified community behavioral health clinics. Recognizing that CCBHCs, as funded by SAMHSA, has really a part of the charge for CCBHCs is to support service members, veterans, and their families. So we worked with a number of partners, some of you who are actually in the room. So great to see you, to be able to partner. Work with a group of SMEs and some certified community behavioral health clinics, to be able to identify what some of the best practices are to support veterans. This is not meant to be all-inclusive. This is meant to be applicable for clinics that are just starting out, or maybe some ideas that you're looking to enhance your efforts. So this learning community is actually building off of a webinar that we recently produced, and the subsequent learning communities in July and August will also feature other speakers from that webinar series. But really wanted to dig a little bit more into the toolkit itself, talk some about the modules, the setup, the way that the toolkit is produced, but also some of the action steps. Definitely love an interactive conversation. So if you want to raise your hand, or I'll be keeping a side eye on the chat. Phil will also be helping me capture questions if I miss some, or we'll be doing some Q&As, as well as keep an eye on the chat. Our colleague Aaron, who is supporting us, is going to be dropping some of the links. Most of the links have a QR code, as you can see here, for the actual CCBHC toolkit. But Aaron will also be dropping those in the chat for you to link and bookmark, or favorite, or ignore if that's what you want to do. But hopefully this will be beneficial for you. So to start off with, want to talk a little bit about the structure of the toolkit itself. Again, if you attended the webinar, some of this may be repetitive, but for those of you who were not part of the webinar, the toolkit is really built around 4 different modules, which we'll talk about in a minute. But each of the modules have some common elements. We have insights from experts. These are subject matter experts, both in the CCBHC administration space as well as the military and veteran space. Notes from the field. This is a section that is really highlighting some actionable tips that are actually being conducted by our CCBHCs that contributed to the publication. Ideas for action. We'll dig into these a little bit more during this session today. This is maybe a checklist that you can see that different ways that a CCBHC can support. And then resources, a number of resources applicable to each of the modules that may be beneficial. And appreciate again the answer to the poll questions. If you are a military and veteran support organization, you might consider how you might fit into one of these four modules, how you might support certified community behavioral health clinics in your community or within your network. So definitely hope that this is beneficial to you. So we had a number of certified community behavioral health clinics that joined us in the development of this module or this publication. So we had Ashtabula, Ohio Community Counseling Center, Ashtabula, Ohio, High Plains Mental Health Center in Hayes, Kansas, Berks Counseling Center, Reading, Pennsylvania, Family Service, Rhode Island, Valley Healthcare System, Morgantown, West Virginia, Community Fairbanks Behavioral Health in Indiana, and then Volunteers of America, Massachusetts, and Jamaica Plains, Massachusetts. These are all clinics that are doing some work related to supporting service members, veterans, and their families at some level, in some way, across these four different modules. We feel like this is a fairly good representation. We have some urban CCBHCs, we have some rural, some suburban CCBHCs. So within each of the modules, you will see how the CCBHCs are actually applying some of the concepts there, and hopefully that can be beneficial to CCBHCs in your community. As I mentioned, we also would not have been able to do this without a number of subject matter experts. These are individuals, again, who have experience within certified community behavioral health clinics, as well as service members, veterans, and their families, as well as individuals from the Department of Veterans Affairs. These are individuals that gave overall feedback on the publication, but also do have some very specific insights related to each of the four modules. So want to get into the four modules. We'll talk about the module, and then we'll have an opportunity in between each of these to talk a little bit maybe about how this might apply to you. But the first module of the toolkit is really about the importance of identifying military and veteran clients. So as many of you know, as I recognize many of you in the room, the question that we often recommend to be asked is, have you or a loved one ever served in the military? That question is very, very important because that's a more broad question than someone being asked, are you a veteran? There are different external definitions of veterans, but even those who serve themselves might not consider themselves veterans, or might not have indicated that they were a veteran, a part of a military and veteran family. So I think that's really one of the big things about this first module is how to identify military and veteran clients within a CCBHC population. Again, the publication goes much more in depth in these, but some of the recommendations are to ask the question, ATQ. You'll hear that a lot in some of this work, but ask the question of have you ever served? Have you or a family member ever served? Then after asking the question, exploring the background, because once someone identifies as a veteran, military family member, helping to identify, well, what are the next steps? What are the next questions that you ask? And then to be able to start identifying those needs. So just saying that you have veterans within the CCBHC, your client population, what are the next steps that you need to do based on the responses of those questions? So that can be very important. One of the things, the next several slides are really going to be talking about those ideas for action in Module 1. So one of the things we recommend is to embed this screening question into all intake forms, electronic health records, if it is applicable, or even assessment tools to systematically identify SMVF clients. New Hampshire's Ask the Question campaign. We just dropped a link in the chat, but this is it actually has videos, some different worksheets talking about how to implement Ask the Question in various different settings. But this is one of the very important things. Those of you who may not know me, I did retire from the Army in 2014, but after that, I became a clinical mental health counselor at a privately owned multidisciplinary practice in Colorado Springs, Colorado. We were in a military town, and so we knew that we had a majority of military clients. We knew that they take TRICARE. That's sort of another way that you understand that individual is affiliated with the military specifically. But really, we made it a distinct effort to be able to ask directly, because once you ask directly, you're then able to capture the numbers of those that you're serving, but also support them in the best way possible. Then it's also necessary to train staff, provide training on the different branches of the military, the different types of service, and the unique needs of service members, veterans, and their families to improve understanding and support. Right now, obviously, many people are familiar with the Vietnam era veterans that are in their probably late 70s, early 80s, Cold War era veterans that served in the 1980s and 90s, Persian Gulf era, and then, of course, post 9/11 veterans, Global War on Terror, 2001 and present. But understanding that while there are similarities between each of these different eras of individuals that served, that there are some differences. Obviously, those I had the opportunity, the honor really, to work with some Korean War veterans who were in their 90s. And so as you higher up on that list there, obviously those veterans are of an older era, whereas post 9/11 veterans, you range from probably the youngest veteran is in their 20s to probably in their 60s because of the length of that conflict. So really understanding the different eras, maybe what the difference is between the Army, the Navy, the Air Force, Marines. A lot of this is some really basic cultural awareness piece, but it's really important that staff at least do some informal training, reading, learning through some self-paced learning, but even formal training can be beneficial as well. Also important to develop a referral system. So if somebody is accessing services at a certified community behavioral health center, those challenges they're experiencing are not likely happening in a vacuum. So again, those of you in the Veteran and Military Support Organization that answer that poll question, you can be part of a referral network. So I can help someone with their mental health needs, but if they also had housing needs or involvement in the criminal legal system, those needs are also how can you make a referral to other organizations that support those different needs. And we'll talk a little bit later about some of those unique needs. But when you talk about identifying military and veteran clients, how do you establish a referral network to be able to do that? Yes, thank you so much. Our colleague Kathy from Star Behavioral Health. You'll see a little bit later that we do highlight them as a resource as well. But they also do provide some very basic, not basic, but their courses do provide some understanding on lived military experience.
Yeah.
Next, under identifying SMVF clients is really to be able to promote awareness. So identifying that your certified community behavioral health clinic is one that has some familiarity or can support service members, veterans, and their families. Some CCBHCs have identified their staff who are veterans themselves with these pins, for example, you see on the left, or honor their staff who are involved in the military. This is a screenshot on the right there from a video that one CCBHC did that really highlighted the contributions of staff, but really promoting the awareness that a CCBHC has the understanding that service members, veterans, and their families are in your client population, as well as in staff, can also encourage clients to self-identify and thereby access available resources. So again, that is just a very brief overview of the first module and some of the content there. I'll hand it over to Phil to lead us in a little bit of discussion.
Yeah, thank you, Duane, for a great outline of that first piece of this. So to the audience and kind of as you all are thinking about it within your own communities, states, your neighborhood. If you want to ensure that your CCBHCs are consistently identifying your SMVF, so at the client, staff, volunteer level, what would asking about military connection look like in your setting, and what barriers may get in the way? And as you're considering that, both the formal points of contact, intake, things along those lines, as well as the informal ones, where does that opportunity arise? Who would be responsible for asking? And then, looking at those different points of contact, how would that approach differ depending on your role? So if anyone has any initial thoughts on, what that connection may look like in your setting, and some of the factors that may contribute to that, both challenges and some of the enablers there.
I think we'd also definitely be interested to hear how you are identifying veterans.
Yeah, Lauren.
In Kansas, when it came to developing SMVF programming for CCBHC and how we collaborated with the VA, we both had partnerships with the VA that could identify VA care in the community opportunities that were looking for outsourced or local therapy and other resource managers. And so we had direct referral from them when we initiated MOU with Eastern Kansas and Robert J. Dole. As a matter of fact, I believe we were the first ones to initiate those, according to our CEO and director in the state of Kansas, to have one with both VA healthcare systems and in Oklahoma. And then on top of that, what we were able to do was we were able to use referral networks that were put together by veteran service organizations in the area to help identify both homeless and casually housed veterans that were making it into the area, both in rural and suburban settings. And while we were putting those two pieces together, the rest just naturally fell into place, because if we're going to ask questions, I'm on the Suicide Mortality Review Committee for the state, and if we're going to ask the question, are you contemplating harming yourself, or are you contemplating suicide, it should be a much easier ask to say, have you or a loved one ever served in the military? And if so, what relationship did you have and what challenges did you know? And when we do that during intake, it just smooths the road from there on out.
Yeah, I think that's a great example of how it would work. How once you start identifying service members, veterans, and their families, and then to be able to connect them to resources. Definitely when individuals are connected to the VA, that's someone, that's one way to know that they are in the military and veteran community.
And I think we have one question from Amy Fierro in the chat as well. Amy asked, does anyone have a small sign or card that asks veterans to identify themselves? We asked the question for clients entering the clinic and screenings, but at large events, I'm also afraid I miss veterans, as I did not get to greet each person individually.
Yeah, I think that's a great way to be able to ask in as many ways as possible. I think that's a way to be able to signal that your clinic is open. Like, we support veterans and would love to know if you have that. Tim, so
we had a training test called the Green Zone, the Community Green Zone in Southeast Kansas, that has covered 13 counties and is working in Johnson County and Harvey and Sedgwick counties as well, that have created badges that show the six branches of service and a green and white flag that are posted at not only PhD locations, but also businesses that were willing to partner with and sponsor events, all the way from helping veterans to helping gather the resources. So we have green flags that businesses all over the country.
Lauren, we're having a little trouble hearing you, but Duane, I don't know if you got any of the.
Yeah, no, I think that in some of what Lauren was talking about is basically finding a way to signal to the community that you do support them, either through word of mouth, but even as you had asked, Amy, is in some way a sign or some type of messaging. Tim, I see that you identified that once you started asking these questions about CCBHCs, about EHRs, electronic health care records, that for some EHRs it's in the process, it's set to off and you have to default it back to on, or it's buried somehow. But otherwise, until you start digging into your EHR and say we don't ask this questions, yes, there may need to be engagement with the vendor of that EHR or EMR system to be able to enable that. Which again, I think even that is a benefit to say that we should be asking this question, and this is one way that hasn't been asking the question. And then Michelle, when you sign up, when someone signs up, they have a screening form that asks specific questions about military affiliation. So again, these are all great examples about the how you would ask and identify service members, veterans, and their families. Well, thank you for that. Next, we want to talk about military and veteran experiences. This is building off of Module 1, but this module is really specifically talking about military and veteran experiences and lived military and veteran experience. And so the need for individuals in clinics to understand this particular situation. In this module, we talk about military service awareness and responsiveness. So understanding the military and veteran community, one is a distinct group, but also has definite, distinct subcultures, if you will. Understand different aspects of military and veteran experiences. So understanding the difference between someone who is in the National Guard or the Reserve components of the services, or versus active military, someone who served for a tour or two, 3 to 6 years, versus somebody like me who spent 20 years plus in the military. And then also the access to care and eligibility for benefits, and what some of those may be, how those may be impacted. So again, building on this concept of training, experiencing some training on military and veterans experiences, including the unique values systems of service members, veterans, and their families. So the Center for Deployment Psychology has a number of videos and courses that have been involved, that provide some military and veteran training, as well as PsychArmor. PsychArmor is a national organization that provides some self-paced learning related to learning about military cultures. This goes, I think, to Amy, and I think even to Lauren's point before of enhanced visual representation. So you can see here a couple of CCBHCs that have very clearly put together something in the lobby that indicates that they do both honor and support service members, veterans, and their families. So displaying military branch flags, emblems of diverse images of veterans can create a welcoming environment. I really like Amy's idea of, even as you're out on a table, if you're a resource fair or something like that, having some sort of sign or say, if you're a veteran, please let us know, or just basically, rather than just relying on the active inquiry of have you ever served, but having some way to provide some understanding that this is an organization, or we are a group that in addition to our work in behavioral health, we also support service members, veterans, and their families. One of the most significant things is, those of you who are in the clinical space know that trust is critical for mental health treatment. I often say veterans don't need much of a reason to avoid therapy, and any reason is a good reason for many veterans to avoid therapy. And trust is really a factor. I'm sure those of you who are in the clinical space, you've heard this from veterans saying that, I don't know if this person has or hasn't served. Can they really understand what I'm going through? I don't want to have to keep explaining myself. So it's important to train staff on privacy policies and effective communication to build trust. emphasizing confidentiality and the importance of understanding past experiences in seeking care. The individual that you're seeing as a service member, veteran, or family member might have had other treatment in the past, and it might not have been very beneficial. It might actually have been a negative experiences or harmful in some way. And so understanding that this individual who is coming in, a lot of it is typical rapport building that we learn in our clinical training anyway. But it is really, really critically important to understand that figuring out a way to be able to develop trust with your military and veteran clients will go a long way for you to be able to support them in meeting their needs. Another really important aspect in this module is we talk about peer support. In some ways, establishing peer support programs that connect veterans with other veterans fosters empowerment, self-determination through shared experiences and mutual support. The Department of Veterans Affairs really in the past several years, and not several years, but really over the last 10 or 15 years or so, have really leaned into the value of peer support. So individuals with lived experience who are also service members or who are also veterans. But also many CCBHCs have created a veteran peer coordinator. Not all clinicians have a military experience like I do. There simply aren't enough of us in the clinical community to be able to meet the needs of veterans. And partnering with peers in some way, having someone on staff who is a trained peer facilitator. They don't need to be a clinician, but perhaps they have some mental health first aid. They understand confidentiality. They have some basic understanding and even in many ways advanced understanding of mental health and wellness. But that is a way to be able to offload some of the mistrust, let's say, is they walk in and they're talking to a veteran coordinator at your CCBHC and say, well, I trust, you can trust me and I trust this clinician, so you can trust this clinician. So it's a way to be able to partner with clinicians who may not have lived military experience. Another thing that's really valuable with peers is they can inform you in your military and veteran program, whether it's hitting the mark or not hitting the mark. One great example of a community-based peer coalition is the New York State's Joseph P. Dwyer Veterans Peer Support Project. So this is across New York State in a number of different ways that have different peer coalitions. So some of this is informal groups, informal networks, but also figuring out a way to be able to engage peer support as a staff in CCBHC. And I would say, especially if you are in a community outside of a military installation, which means you likely have a higher level of service members and veterans. And this doesn't even necessarily, this definitely is not, I want to say even necessarily, isn't just limited to veterans themselves. So military children, my daughter and my son, when they went to college, they were identified as children of a military family and connected. The veterans program reached out to them because they were identified as military affiliated. And maybe that's a way, is creating a peer program for military children or military spouses or things like that. The next is collaborating with veteran organizations. Again, really appreciate having individuals who are here in CCBHCs. Many of the military and veteran support organizations want to partner with CCBHCs. Like they provide some support in other material things like employment or financial support or housing, but they don't do behavioral health work, right? So many military and veteran programs would like to partner with CCBHCs as well as having a reciprocal relationship. And these partnerships can be clinical partnerships, things like the Cohen Veterans Network, the Avalon Action Alliance, the Avalon Network, Warrior Care Network with the Wounded Warrior Project or the Headstrong Project. There are some national organizations that provide some things, but then there's also local organizations such as the Be Connected program, and I say local, state and local, but the Be Connected program in Arizona is a definite example of a military and veteran organization support network. And the Military and Veterans Affairs program in Los Angeles has the Veteran Peer Access Network, which is sort of a phone line that veterans within Los Angeles, 10 million people, 200,000 veterans, but they have a specific program. And one thing I always recommend is your state or the national IRS tax exempt database. Take a look, search in there for veteran organizations by zip code, and reach out to them to be able to start building and collaborate with that. So I see some stuff in the chat there, but I'll hand it over to Phil for some conversation.
Yeah. As you digest some of that chat going on there, I will tee this up for the group. As we all know, I think this audience is very familiar. Military families often do carry that weight of a service member's or veteran's experience without being recognized as having their own distinct needs. How could you, or is your organization accounting for some of that? Has that been a consideration? And alongside that, what are some of the community or peer resources that exist specifically for military families in your area? And how connected is your organization to them? And along with that, also, as you were thinking about the assessments and, asking about military service, is there questions that surface family members' own stress, isolation, or service related impacts as well? So are you including the family member aspect into asking those questions and providing those services?
Definitely interested in if anybody on the call has experiences. And again, this is very specifically, it's not service members and veterans, but family members, children, spouses, even parents, perhaps. Very often when we have these discussions, this is sometimes the response that we get, because many people, again, and even CCBHCs, they're focused on supporting service members and veterans as one of the requirements, but then family members not necessarily. Shannon.
Yes, so we have like the Blue Star Moms or the Oklahoma National Guard's Military and Family Office, and we partner with both of those, and they can help support our families. And then just the VSOs that are around the area will help the military families as well. And so we do lots of, we have MOUs and we do partnerships with them. And so we take referrals from them and we get referrals to them. Our intake process, like questioning when clients call in to the clinic, includes military family members. So if they are a veteran, a military member, a family member, that automatically ticks them into our Veteran Services Team referral process. And they go straight to us and bypass the normal clinic intake process.
Yeah, that sounds like a great program. So are you with the CCBHC in Oklahoma, Shannon?
Yes, we are. We're CCBHC in Northeast Oklahoma, or I guess Eastern Oklahoma. Creoaks is who we are.
Yeah. Again, I think that's a great example of relying on a network, and again, this idea of mutual referrals. CCBHCs can also support military families. When I was doing clinical work, we actually had a group for military wives, and I co-led this group for military wives. Some of it because they were able to ask me questions that they wouldn't be able to ask their husbands, right, or their spouses. And so this was a way every Wednesday night, the kids were taken care of, and this was a support group, a clinical group, a processing group for military spouses. So thinking of some way to support families.
Yeah, the op tempo is picking up in Oklahoma. So we have increased efforts to start outreaching to our school-based services. So we've got that list isolated, and we have our designated case managers that are actively working with their school-based services to start reaching out to those families that are engaged in services and other programs so that we can start creating those kinds of connections. Exactly.
Yeah. Op-tempo, increased deployments or increased training cycles. Again, if you're in a military and veteran community, you know that these things are happening. When I started to deploy to Iraq in 2006, my kids were in kindergarten and first grade. And when I stopped deploying in 2013, every year for all or part of the year between those times I was gone, they were approaching high school, right? So supporting the family, not to mention, are the spouses during that, but really supporting the children. Programs like Blue Star Families or the Purple Star program, but Blue Star Families is another great resource too. But many schools are identifying as Purple Star schools that have large military and veteran population that have specific coordinators for that. Also, definitely appreciate the peer support encouragement. Paul definitely returned from the Gulf War. Peer support was grassroots efforts, and again, I think this is something you hear from Vietnam, Gulf War, and even some of these things today. But figuring out a way to incorporate peers into your efforts is definitely beneficial. Next, want to talk about the next module. Again, some of these are building on top of each other, but this module is really talking about key partnerships for service members, veterans, and their family support. And so in this module, we talk about partnerships, obviously, with the Veterans Health Administration, but the Defense Health Agency is another critical partner, especially with TRICARE, but then partnering with other organizations in the military and veteran support network. Again, we talk about the different efforts related to making these partnerships. So first, we talk about establishing formal agreements. So developing memorandums of understanding or agreement with local VA facilities. You heard Lauren talk about Kansas, and Kansas being an example of how memorandums of understanding between CCBHCs and the Department of Veterans Affairs can really be beneficial. Actually, in the toolkit itself is an example of one of the MOUs from Kansas, from the VA side. So this was developed, a memorandum of understanding developed by the VA for CCBHCs rather than CCBHCs. You'll see here Community Counseling Center of Ashtabula, Ohio, and VOA Mass. Both of those were generated from the CCBHC and have memorandums of agreement or understanding. Some of the conversations, and I saw this a little bit higher up, sometimes VAs will say, well, you should enroll as a community care network partner, and that would supersede a memorandum of understanding or memorandum of agreement. But as was identified, it's not required that the CCBHCs enroll in TRICARE or the community care network. The requirement is serve service members and veterans. One of the ways to do that, yes, is to panel with TRICARE and in the VA's community care network, but also reaching out and figuring out how to engage with your local VA. The VA is a very, very large healthcare system. The problem is there's lots of phone numbers, but the good thing is there's lots of phone numbers, right? So engaging with your local community engagement partnership coordinators or engaging with someone in the VA and talking about how you might be able to collaborate with the VA through an MOU or MOA can definitely be beneficial. Again, we have copies of these different memorandums of agreement are in the toolkit. Another thing, again, it's not necessary and it's not easy. I recognize that my role in my clinic was as the director of veterans programs. And please forgive me, those of you colleagues who are on the VA, but from a provider's side, the community care network can be challenging, TRICARE can be challenging, Military One Source. Paneling with these, just like with any other insurance, paneling can be challenging, but this is a way to be able to support that. So the VA's community care network, this is, and for those of you and us who have been around for a while, this is the VA's fee for service. Now they actually conduct referrals to community. It can be difficult in engaging, or it can be challenging to get it on board, and it is something that you need to continually engage in the process. But again, it is a way to, one, receive clients, receive referrals from the VA, but also to be able to engage with that back and forth referral. TRICARE is another one, paneling with TRICARE and paneling with Military OneSource. One thing I do want to point out here is that if you're not familiar, we often say partner with the VA, partner with the Defense Health Agency and TRICARE, or the DOW with Military OneSource. But all of these programs are actually managed by a third-party administrator. So you're not actually, some of the challenges, and I hear from my VA partners is like, well, that's not us, that's Optum or that's TriWest. And so understanding that, yes, as a CCBHC, you will be working with that, is that you will be working with a third-party administrator. Another thing that we have seen to be beneficial is facilitating staff engagement. So inviting behavioral health clinic providers or vet center providers to an open house to your CCBHC, so you can show them what it's like in the resources that you have, or attending their open house days. One of the things that we did in Colorado Springs is our local community-based outreach clinic, CBOC, had community resource days once a month in which they would bring in community organizations and foster some conversations, but it was held right there within the VA. So to develop or facilitate staff engagement events is a way to be able to build relationships. That's really what a lot of this is you can say, I'm going to refer you to the VA, or VA is going to refer you to the clinic. Well, then the VA nor the clinic is an individual. Like Janet at your clinic is going to refer to Rob at the VA. Like that's how these things can really be beneficial. So figure out some way to be able to engage staff connections. And then engage with local veteran service organizations. So partner with local VSOs, nonprofits to offer wraparound services. Again, this is the idea of some strong partnerships. The National Resource Directory is a great resource where you can search by city, state, zip, and be able to identify some resources that may be in your area. Another way to partner is to participate in community collaboratives. The SMVF TA Center, we support the VA SAMHSA Governor's Challenge to prevent suicide among service members, veterans, and their families. That is an effort that has established suicide prevention coalitions specifically for service members, veterans, and their families in all 55 states and territories. So you can reach out to the SMVF TA Center to be connected to your local Governor's Challenge. Or the American Serves Community Network is another one that has specific coalitions in a number of different areas. So participating as a member in these community collaboratives, or at least engaging with them, letting them know that you are in the community, supporting and wanting to support veterans, have the ability to support veterans, but also that you're able to lend a measure of perhaps behavioral health expertise that they may not have. So I see some questions in the chat, and I'll get to those, but I'll hand it over to Phil for our next sort of discussion real quick.
Yeah, thanks, Duane. So as we're building off of that module there, thinking about veteran and military service organizations and community nonprofits and the deep trust that they already may hold with service members, veterans, and family members, how can a CCBHC build partnerships with those organizations? So if you're in a situation where some of those partnerships have already been established, how did you go about that? How did you go about that trust building? And in thinking about that, what does your own organization bring to the table that those veteran service and military service organizations may need? And what do they bring that you cannot replicate? And how are you ensuring that those referral relationships are genuinely reciprocal?
Lauren, I see you have your hand up.
First of all, I want wanted to kind of touch on something that you had said a moment earlier when you were discussing the different services that were difficult through the paper service under a community care network. It is well known, especially in the state of Kansas, that we are working on trying to create a parallel peer support network because they end up paying for paper service of both the and the MOUs that we have. The VA does not pay for any services that can be rendered as specialty services at the VA itself. So even though we have up to 200-mile distances between people in their nearest VA, you can't get a VA paid peer support service from a community provider because VA will only cover peer support services at VA centers. So we partnered with Growing Veterans from Washington to establish a certified peer support program that was aligned with veterans that could be offered to them through a counseling track and allow them peer support even though it was not a paper service. So sometimes your network has to stretch even outside of the borders of your normal reach. You have to think outside the box to make those happen. The other thing I was going to point out is that whenever you're creating networks, many people are trying to reinvent the wheel when there's already really good blueprints out there. And so when you have programs that like the SMR or the Governor's Challenge, SMR, for those who don't know, Suicide Mortality Review, or you have a state organization like an SMVF subcommittee of the Governor's Challenge. I'm a part of all of those, and being able to bring those together as a nexus for service is a way that people can maximize their reach through parallel representation. So if that helps.
Yeah, no, I think that does definitely help. First, to your point of yes, the VA's community care network does not pay for all of the needs, perhaps or services. And again, we recognize that the system is not perfect, nor is any system, but figuring out a way to be able to manage that. I think that some of that I was looking in the chat. One of the points is one of the challenge, Colleen, you identified one challenge is that community-based organizations that are part of the community care network aren't required to have training such as ATQ or STAR behavioral health lived experience training. And that's accurate. I think that is one of the that many people have identified as maybe a problem with the community care network is providers that sign up. There's not a requirement, a federally legislated mandated requirement to receive military culture training. And yet it's the best thing to do to support the clients and do the thing. I think that's one of the things that we're trying to recommend, that even though there is not a federal requirement that this be part of your annual training, for example, that perhaps it should be, right? Or figuring out some way to better serve your clients to be able to develop some measure of military culture. I think I saw also, Lonnie, you said that in your rural community, limited amount of providers that will give assistance due to lack of knowledge. Wondering if you'd be willing to expand on that a little bit more. I'd love to hear more about that. Sorry if I'm putting you on the spot, Lonnie, if you're there. But and so I think that that is a critical piece. Many people say, well, I don't want to. A CCBHC may not say that I want to highlight that we work with veterans because do no harm, right? We don't want to work with veterans because we feel as though that we're not.
Okay, I'm
Oh,
here.
there you
Sorry.
are, Lonnie. Thank you. I saw that.
Yeah,
I
sorry.
was tap dancing. I know how to juggle, but not very long.
Right. I was thinking too hard on how to actually unmute when it was so easy. So I have my coworkers all laughing at me. Whatever. Yes, just the lack of knowledge we have in our rural community. Um, our there is because I work for Columbia Wellness, so we're a mental health facility. And we are not part of the community care. We don't have providers that can take TRICARE or VA insurance. We have mental health, a place, just one that accepts like TRICARE or that's on the community care, but that's it. We have limited amount of people that are willing to get set up with all those to be able to service our veterans. So we have two VA facilities, one up north in like Seattle, so that's the South Sound region, and then we have in American Lake and Olympia, and then we have the VA in Portland, and they have some C-Box in Vancouver. But either way, in our community, people are driving over an hour
Right.
to receive the service that they could most likely get in our rural community, but no one willing to step up and get the credentialing or invest or look into or those types of things to better service the veterans in the area.
And again, I think as you mentioned, a lack of knowledge or, overcoming the barrier. But people say, well, I don't know enough about military and veteran experience to be effective. I had
Right.
a friend of mine who was a Marine who went to therapy, and his clinician, who was not a veteran, said to him, well, I don't know if I can help you because I'm not a veteran. And he said, well, I don't need help with my veteran stuff. I need help with my human stuff. Like
Right.
that's the piece of helping clinicians understand, is like, you don't have to have lived experience in this community. Just looking at it from a multicultural lens, that we don't have lived experience in everyone's community, but we have training as clinicians on the different conditions. And so I think
Right.
that is something that can be very beneficial. I also think that connecting with others, maybe I think I saw somebody in the chat that said they're in the Pacific Northwest, but others within the state of Washington or regionally that may be able to engage with your clinicians and provide, if it is due to a lack of knowledge or a lack of willingness, not to say willingness to connect, but the idea of do no harm, to be able to provide some support and get people more comfortable, that could be beneficial as well.
Right.
Well, thank you for that.
Uh-huh.
So, and I think, Phil, I think I've got the chat. Is that right?
Yeah, I think you're up to date. Just Paul had mentioned a note about coffee socials can be a good
Yes.
two-way communication as well.
Yeah, Paul, do you want to talk a little bit more about coffee socials? Definitely. So there's some VA efforts or some local efforts. Again, I know I'm throwing people on the spot there, but yes, I think that's another great example of even as informal as the McDonald's on a Saturday morning, and you can tell that it's a group of veterans in the corner having some coffee, right? So one, they're connecting and they're engaging, but also there's some similarities. Oh, and I see Dr. DeSola from SAMHSA. Thank you so much, Leela, for joining us. Leela, if you would see the toolkit, was one of our colleagues at SAMHSA that was very, very instrumental in developing this toolkit. And she identifies that veterans frequently drop out of care during complex administrative transitions. Like I said, veterans don't need much of a reason to avoid therapy, and too much paperwork is a reason to say, well, I'm just not going to go through this. I'm just not, this is too hard. Not that it's too hard, but that this is challenging, and that need to be able to overcome those kind of things. Um, and Amy, thank you. So Amy dropped a link. No, yeah, absolutely, Paul. No worries. But Amy dropped a link to the Recovery Cafe networks, and so this idea of some measures of community events for veterans. Next, we're going to talk about Module 4, Clinical Considerations and Life Circumstances. And so this module is really specifically talking about different areas, both clinically and in life circumstances in which veterans have some experience. And so we wanted to specifically include this content in the module. I frequently say that this content is like an overview. Like we're not even rubbing the surface, much less scratching the surface of all of these things. Each of these different things could be a toolkit in and of themselves. But to be able to help CCBHCs understand that some of these different areas, some of these different efforts are necessary to be aware of. Again, I'm going to go through this pretty quickly. I'm not necessarily going to go. We have had some presentations. Actually, I think I saw a colleague, Scott Cherokee, where I joined him and some colleagues in Southern California at the beginning of May, talking about each of these things more in depth, specifically for some veteran courts in Southern California. But really, the idea here is to, if you're not familiar with or have experience in the military and veteran community, to understand that it's more than just PTSD and TBI. I think when I often talk, and if you think that there's the pie of mental health for veterans, if there's two slices of the pie, PTSD, and of course now traumatic brain injury, many people are starting to consider that. But really helping individuals, clinicians specifically, that are do not have military and veteran experience to understand the broad range of needs. And again, not to say that these are exclusive. This is just a way to visualize some of these things. So, of course, you think about post-traumatic stress disorder. I recognize that there are different terminologies here. Some individuals discuss it as post-traumatic stress or post-traumatic stress injury. TA Center, we talk about it specifically in the Diagnostic Statistics Manual 5, actually 5TR, as the listed disorder. So talking about post-traumatic stress disorder and recognizing that and the different interventions for that, as well as traumatic brain injury. Traumatic brain injury, especially as we have advances in medical care, advances in equipment, safety, that there is greater survivability from catastrophic injuries that previously would have been fatal in earlier conflicts, but that also results in more catastrophic wounds, such as traumatic brain injury. But beyond that, also understanding that there are substance use concerns and addiction concerns if you think about process addictions such as gambling. But substance use concerns within the military and veteran population. The opioid epidemic in the veteran population really started with the very physical and often demanding needs of the military. I often say I jumped out of airplanes 37 too many times in my military career, and I have the neck, the back, the knees, and the ankles to prove that. Beyond that, there are mood disorders, and generally we talk about, and in the toolkit, you'll see specifically we talk about anger, anxiety, and depression. Yes, post-traumatic stress disorder has an emotional component to it, emotional dysregulation component, but also recognizing that there are things within the military that can cause someone to develop generalized anxiety disorder or major depressive disorder. And clinicians, and I think to the point we were having earlier, clinicians are trained to address those disorders. It's just the military aspect is different. So these 4 conditions that we identify here, these are all clinical diagnostic criteria that are listed in the DSM. There is significant research in both the condition itself and the interventions for them. It's not limited to military experience, although it does have unique etiology related to military experience. Much of when I was working in Colorado, I realized that Colorado had some very, very good, extensive brain injury treatment, not because of our military population, but because people don't wear helmets when they ski downhill. And so skiing accidents results in a lot of traumatic brain injury. And so substance use and addiction, we know is prevalent across the U.S. population, mood disorders. Insurance coverage for these, not just TRICARE, but just general insurance, but also specifically for veterans, disability compensation is available if these conditions are considered service related. These conditions are conditions that are emerging into a concept called transition stress. So my colleague Megan Mobbs and her colleague George Bonanno in 2018 identified these conditions, among others, as transition stress, which is the psychological strained experiences they adjust from military to civilian life, both while they were in the military, leaving conflicts, coming back to stateside, or leaving the military altogether. Really redefining identity, establishing social connections, and adapting to norms and routines. Moral injury is an emerging concept, first identified in the mid to late 90s by Jonathan Shea as he worked with Vietnam veterans, but has also definitely become identified through Dr. Brett Litz and Shira McGinn and their colleagues around 2008, 2009 that really defined moral injury. So moral injury is really the way that an individual sees or thinks about right and wrong in the world has been fundamentally changed by their military experience. The understanding moral injury as a condition and how to engage in it in a clinical space is very important. Needs fulfillment is another significant aspect of this. When I was in the military, I never really had to worry about if I had something to eat or where I was going to sleep. The quality of those things weren't always great, but at least they were there. I had the resources, I had the food or the housing. But also, if you think about Maslow's hierarchy of needs, your social group is created for you. Opportunities for advancement and self-fulfillment are there. And now, when you leave the military, you have to learn how to meet those needs in a different way whenever you had an organization that met those needs, that provided those needs for you. So understanding that there is that challenge. Purpose and meaning. This goes to Mobbs and Bonanno's personal identity. When in the military, while in the military service members had something that was personally fulfilling to them. Again, not universally, recognizing that not all military services is wonderful. But in general, there was a sense of satisfaction, meaning, internal satisfaction, as well as a sense of purpose. I'm doing something that is meaningful. I contribute. I may be a cog in a machine, but I'm an important cog. All the cogs in this machine are important. And then when you leave the military, how do you find that? Especially if you're used to finding it in the same place. That same Marine buddy of mine that shared about his clinician and going as clinician for human stuff. He was a squad leader in Helmand Province in Afghanistan, responsible for the lives of 12 Marines and millions of dollars worth of equipment. And he gets out and he goes to work at a lumber mill, and they hand him a broom and a dustpan. And his job was to sweep up sawdust. And he lasted 3 days. He was like, this is not what I signed up for. Like, this is, what did I do? I'm thinking about getting back in the Marines. So this is straight 100% existential psychology. Rollo May, Urban Yalom, Man's Search for Meaning is definitely something that I have even recommended to veteran colleagues and even clients, talking about how Frankl's concepts in Man's Search for Meaning really resonate with a lot of veterans. And then finally, relationships. Our mental health impacts our relationships, and our relationships impact our mental health. This is critical. We're not just talking about intimate partner relationships, but relationships with parents, relationships with siblings, extended family members, social colleagues, work colleagues, and so on. So again, these are not necessarily defined in the DSM. There's no DSM criteria for a lack of purpose and meaning. And arguably, some people who are doing research in this say that it might not necessarily need to be in the DSM, but there are variable amounts of research, but they all do have significant impact on mental health and well-being. They're likely more prevalent in the military and other service organizations such as first responders that may not necessarily be prevalent in other industries. And insurance coverage and disability compensation are not as broadly available. Many times when we were working with veterans, They had to have a primary diagnosis of one of those on the top while we were also working on moral injury or solution-focused brief therapy to support needs fulfillment. And if that were not enough, I feel like I'm sometimes, um, uh, the guy selling stuff on the TV. But wait, there's more, right? The different circumstances that we list in the toolkit here talk about more than just the sort of the standard clinical things, but these are all things that impact mental health just as much as things like post-traumatic stress disorder, moral injury, or family concerns. So justice involvement. Much of my early clinical work, all of my early clinical work when I retired and started in my clinical space was with the Fourth Judicial District Veterans Court. And so on Tuesday, I went to jail. On Thursday, I went to court. I was able to leave both places, thankfully. But working with veterans, sometimes because of these challenges in their behavioral health or psychological health, find themselves in the back of a cop car and find themselves involved in the criminal legal system. Again, in the toolkit, we talk about partners. Local veteran courts are definitely one. Veteran justice outreach is another. Another significant life circumstances to consider when you're working with military and veteran clients is personal exposure to suicide. So how much that individual has been exposed to suicide in their own personal lives. We recognize that the more one is exposed to suicide, the higher the risk for suicide thoughts and behaviors themselves are. I don't know of a veteran who has not lost one or several, or in some cases, many of those that they served with to suicide. I have lost more of my fellow service members that I served with to suicide than I did through combat or other causes when I was in the military. And so it's highly unlikely that you have a military or veteran client that has not been exposed to suicide in some way. So understanding that that is a risk factor that might be a little bit more unique to your military and veteran clients. We do want to identify that this very specifically does not refer to asking someone if they are experiencing suicidal thoughts or behaviors. That is not exposing them to suicide. That is an evidence-based intervention that we recommend that is done. Ask very clearly, are you thinking of killing yourself, self-harm, and things like that? So understanding that personal exposure to suicide is a risk factor. Chronic medical conditions. Again, I talked about my neck, my back. I've had nightmares of my left leg falling off based on my military experience. But there are chronic medical conditions. Chronic pain exacerbates mental health and wellness. Insomnia, very specific. Again, thank you very much to my colleague, Kathy, for sharing that piece of insomnia is a very specific medical condition that definitely impacts our psychological health and well-being. And so understanding that this is something that is the medical doctor, right? So your client, not to say that all veterans are universally damaged or injured or something like that, but if your client in the clinical space, mental health space is coming in, there are likely some medical conditions that might be exacerbating some of their mental health conditions. Next, barriers to care. So understanding that there are barriers to care. Again, Dr. DeSola identified earlier is significant administrative burdens will cause a veteran to disengage in treatment. But even you talk about barriers to care, I think we saw earlier just the distance. We were here talking about that earlier. And there's veterans like to get away. I had a veteran that said he was 50 miles away from any resources, and he liked that until he needed those resources. As well as barriers to care, we talk about characterization of discharge. If you're not familiar with military and veteran culture or experiences, understanding that the manner of discharge, and I'm not talking about dishonorable discharge, but other than honorable discharge, the difference between a general under honorable conditions and an other than honorable discharge can be significant when it comes to accessing resources. I'm just rolling along. Lauren, I see your hand up. Please give me a break. No, go ahead.
Two things I want to touch on with that. One, when you're working with CSM-based things and still handling moral injury, we have found and whether or not to classify something as combat stress or the longer term PTSD. And then the other thing that I was going to touch on was what you were just talking about, and that was that most of those resources to help partner with that when you get into those areas. A lot of veterans in our rural communities, which and Western Kansas both have, Southeast Kansas and Western Kansas both have a lot of, is the home-based primary care team with the VA will often partner with local providers that help provide services to veterans in extreme rural areas to include telehealth, and they'll engage local providers to go out and help facilitate telehealth so that they're not doing it strictly digitally, but digitally with a human component.
Yeah, no, I thank you so much for that, and I appreciate that insight, both on the yes, sometimes in flipping back here a little bit, sometimes a diagnosis of one of the top ones can give you a placeholder for the bottom ones. But then also, yes, the resources that the Department of Veterans Affairs, again, in the toolkit, very clearly we share that there are resources within the VA that can support each of these different things, to include case managers that support barriers to care and things like that. Another life circumstances that can impact is housing instability. A colleague of mine who is also a veteran, who's a marriage and family therapist, said it's very hard to talk about your inner child if you don't know where you're sleeping tonight, right? So the challenge of housing instability and understanding that and overcoming that can be difficult and impactful in mental health, as well as financial instability. We definitely know that financial instability is a risk factor for suicide. And then these last three, as we're going around clockwise, isolation, perceived burden, and access to firearms and other lethal means. If you think about Joyner's interpersonal theory of suicide, these are those three elements of interpersonal theory of suicide, that if these three aspects are present in any one individual, then they're at greater risk for suicide. And that means isolation. Again, and Lauren, talking about Western Kansas, I used to drive from Colorado to St. Louis, where my family's from. So Hays, Kansas, Colby, Kansas, Southern Kansas, and all of the every state has these extreme rural areas. And so sometimes veterans do want to maybe separate themselves, but there's a difference between solitude and isolation. And if a client of yours is withdrawing themselves or distancing themselves, that could be a risk factor. Perceived burden. So think about an individual who, when they were in the military, you don't want to be the weakest link. You wanted to be the one, you were the one perhaps that individuals relied upon. And yet I can no longer run a 18, 16, 12-minute 2-mile, whatever it is, right? I'm no longer able to do the things that I used to do. And therefore that means I am blank. I am a burden. I am not helpful. I'm weak. Like all of these negative self-talk. And then the third aspect of Joyner's interpersonal theory of suicide is the ability to enact lethal self-harm. So that the ability to overcome perhaps some of the reticence that we normally have to enact self-harm. Well, in the military, that's what you're trained for in basic training, regardless of what you do, is to enact lethal harm to others. And it's not much of a leap to be able to, or to have that sort of natural disinclination overcome. And the fact that veteran deaths by firearms is higher than non-veteran deaths by firearms. And some of that is due to access to firearms, familiarity with firearms, and so understanding that these different conditions. And again, we have I've done entire webinars just on these conditions, but just wanted to give you an understanding of some of this stuff. And I see that we have about 20 minutes left. Definitely appreciate the conversations that are happening in the chat. Thank you so much, Leila, for sharing your thoughts, and Colleen, Paul. Thank you all, and I'll do my best to get through this and at least have some conversation and leave time for Phil at the end. But really, again, now, so these different parts in the toolkit talk about implement comprehensive screening protocols. So the VA DoD clinical practice guidelines, or VA DoW clinical practice guidelines, these are guidelines that have been produced specifically for some of these conditions that I just mentioned. Create inclusive treatment and safety plans. The VA's whole health program, again, you'll see some of those whole health programs to be able to provide some of these different aspects, but also, for example, the Stanley Brown Safety Plan, understanding that that is a way to be able to support military and veteran clients in your clinical community. Coordinate case management. So case management services, we talked again about a veteran peer coordinator, or partnering with case managers in programs in the Department of Veterans Affairs where you're providing support in your CCBHC for behavioral health or mental health support, where they are helping with some case management. So the VA, here's some examples. The post 9/11 military to VA case management program, the MAHICM program, the mental health intensive case management program for veterans at the VA. So not just, and I think the goal here in this module is not just to think about the clinical care, the treatment of the mental health conditions, but also how to partner to address others. Here it is. And I appreciate my colleague again, Kathy, so much. She dropped a link in the very beginning, but then not only does the STAR Behavioral Health Program, starproviders.org, not only do they provide some basic military, not basic, but some foundational military experience education, but they also do provide some very, very very valuable higher level training specifically for clinicians on some of these gold star standard treatments for things like post-traumatic stress disorder. They have modules for moral injury and some of these other conditions. So again, not just saying that staff needs to learn about military and veteran culture, but getting some very specific clinical training on conditions related to that. And again, building a referral network. So the Vet Resources Community Network from the Department of Veterans Affairs, the Bob Woodruff Foundation has the Got Your Six Network. So these are large networks or even local networks, your local community veterans engagement boards, but local networks that are able to provide some connection to support those life circumstances, and some CCBHCs and some of our partners in the toolkit, such as VOA Mass. They also were not only CCBHCs, but they were also SSVF providers, supportive service for veteran family providers, which supports housing insecurity. So some CCBHCs have a larger network within their organization to support some of these other life circumstances. Phil, I think I've given you like 7 minutes left, maybe to if you've got one or two things that we can engage with.
Yeah, thank you, Duane. And final kind of question as we round things out here, and especially based off of what was just discussed, as many SMVF are facing life circumstances that are not primarily clinical, but do profoundly affect behavioral health outcomes. How is it that your organization addresses those factors without stepping outside its scope? And what, along with that, what are some of those community resources, any cross-sector partnerships that your organization may currently be using? And then, when we do a follow-up on some of those non-clinical needs, how are we documenting that? How are we making sure that there's a closed loop referral system in terms of that? So some things to think about. Anyone want to comment on these pieces here, or any questions more broadly as we wrap things up?
I think the question here is definitely, as behavioral health clinicians, again, recognizing that not everybody in the meeting is staff or a clinician of a CCBHC, but many times we want to treat the behavioral health condition. Like, what is the diagnosis that we're working with? for the individual in the room at the time. And what we're trying to be able to support is to say, how are you addressing those other things? Not that you're helping the veteran solve those, obviously, advocating for themselves. But if you are a clinician working with veterans, how are you ensuring that those needs are met without stepping outside of your lane, so to speak? Shannon, please.
So our teams, we have like veteran service teams at each of our CCBHC clinic locations, and each of those teams have culturally trained case managers, and a lot of them, they're veterans themselves. So they are trained or connected to already the veteran service organizations that can provide resources and support. And my lateral counterpart is does the outreach and connections with those resources. So it's super easy for us to identify a housing need. Like they said, I saw a chat somewhere that said they couldn't think about their inner child if they don't have housing. It's really easy for us to reach out to a housing connection, to connect with our SSVF partners, to walk them into the VA and make sure that they are connected to case management or get them connected to their primary care. But we utilize specific case managers for our teams at the CCBHCs to address those needs outside of the therapeutic space.
Yeah, again, I think that's a great example. Maybe on the next version, we'll have your organization highlighted in the toolkit as well. But again, that is a very great example of how a CCBHC is addressing those needs without solving those needs or being like, again, very specifically, you are a certified community behavioral health clinic supporting behavioral health needs, mental health needs, while also recognizing that there's those other needs as well. So thank you for that. Okay, so I think I will hand it over to Phil to wrap us up.
Yeah, thank you. And, fantastic discussion by everyone, and thank you, Duane, for walking us through those modules and leading us through those discussions. Optional homework, if you've been familiar with these learning community series, we always like to leave with a little bit of, kind of some thought work as you go home. Thinking about how you may use the CCBH toolkit to conduct an organizational self-assessment that includes all 4 modules that were outlined today. So really taking back, digesting the information that was presented today by Duane, and digging into that toolkit and some of those resources that were provided a bit more as you kind of think of this for your own organization or your community more broadly. Just a little bit to take home. Next slide, please. And our ongoing RAND webinar series on advancing data policy and prevention for SMVF. This 6-part series is really focused on the military to civilian transition and how data research and some of those policy insights can inform our programs and services and our overall strategy. So if you are interested in taking part in this webinar series, you can do so by accessing that QR code through the registration there. Also these slides will be made available. So if you can't capture right now, no worries. You'll have a chance to do that after the fact. And I also see Aaron has put our eval in for today's session. So please take a minute. Should be 1 or 2 minutes to complete that. The slide in front of you is how to make sure you're keeping up with everything, the latest and greatest of what's coming down the pike in terms of our technical assistance, any upcoming opportunities, resources, any of our virtual learning opportunities. So to do that, you can access the QR code here. You can also do so through the SAMHSA.gov SMVF TA Center webpage as well. Next slide. All right, and that brings us our next session will be a continuance of this series here. And we got the great overview and kind of walking through the modules and some of those examples. And the next session will really be about applying that toolkit into practice, some strategies for serving SMVF. So please be sure not to miss that one. That'll be taking place on July 30th. same time and through the Zoom platform as well. And next slide. And that's everything. So thank you all very much. Thank you again, Duane, for the fantastic presentation, and everyone for your participation throughout and the great chat. If you do want to reach out for any reason, you can do so through the SMVF TA Center email right there, or reach out to any of us individually. Thank you so much, and have a great rest of your afternoon and a happy 4th.